Amniotic fluid embolism. It's probably one of the most feared obstetric emergencies you will ever have to face. As an EM registrar, you've got to have a plan for when all hell breaks loose. So, this is your high-yield guide to navigating the chaos. Right, let's dive straight in. Just picture it. You're in the middle of a shift, everything's going fine, and then your peripartum patient has a sudden, absolutely catastrophic collapse. The clock is ticking, and every single second counts. Okay, so your mind is racing, trying to put the pieces together. What you're likely seeing is the classic, terrifying presentation of AFU. It usually happens in two phases. First, this massive cardiopulmonary collapse, and right on its heels, a devastating coagulopathy. So first up, profound hypotension and shock. And look, this is not a slow decline. It is an abrupt, lights-out cardiovascular collapse, and it often rockets straight to a PEA arrest before you can even get a full set of obs.
Next, your patient is acutely short of breath, they're cyanosed, they might even be in respiratory arrest. What's happening is this acute pulmonary hypertension is causing the right ventricle to fail, and the patient just cannot oxygenate. It's that simple and that terrifying.
And then, to top it all off, a generalized seizure might be the very first sign you see. This is a huge, massive clinical clue because it's almost immediately followed by this profound, rapidly developing coagulopathy that leads to unbelievable hemorrhage. Okay, this is a critical moment. AFE is a clinical diagnosis of exclusion, which means you have to be rapidly thinking about and ruling out the other big, bad causes of peripartum collapse. Your next move completely depends on it. So your differential is pretty broad, right? But there's one sign that just cuts through all that noise. While a massive PE can look really similar, it's the sudden onset of seizures that should scream AFE at you. That is the key differentiator. All right, so you've got a really high index of suspicion for AFE, but how do you find the actual evidence to back that up, right in the middle of a full-blown resus? Well, your initial bedside tests are just going to be screaming massive cardiopulmonary failure. You'll see a gas with a shocking acidosis and hypoxia, an ECG showing right ventricular strain. It all looks almost identical to a massive PE. And this is the pearl you've got to remember for your exams and for your practice. If your crashing peripartum patient is seizing, AFE has to be right at the absolute top of your list. But this is the lab test that really helps to clinch it. The coagulopathy in AFE is just profound, and a fibrinogen level dropping below 1.0, well, that's pretty much your single most important diagnostic marker. Okay, you have your working diagnosis. Now what do you do? This is where all that structured recess training kicks in. It's time to act, and act decisively. So you're immediately going to run through your primary survey. The key thing here is anticipating that deterioration and securing the airway early, making sure to use your pregnancy-safe RSI modifications. Get huge access, get an ART line in for monitoring, and treat any seizures really aggressively. Now this is not a suggestion. It is an absolute imperative. The second you even suspect AFE, you or someone on your team must activate your hospital's massive transfusion protocol. Do not wait for the labs. You do not have time. And this right here is the core of your hemostatic resuscitation. You're fighting a consumptive coagulopathy, so you literally have to replace everything. You're going to transfuse packed red cells, fresh frozen plasma, and platelets in a balanced 1:1:1 ratio. Okay, so beyond your standard resus, there are some really specific obstetric and advanced interventions that are absolutely critical in AFE. These are the moves that can genuinely change the outcome. Right. If your patient arrests and has a gravid uterus over 20 weeks, the clock starts now. You have a 4-minute window to start a perimortem C-section with the goal of getting that baby delivered by 5 minutes. This is all about improving maternal venous return and giving both mom and baby a fighting chance. Your therapeutic toolkit is vital. An adrenaline infusion is going to be your first-line pressor for that cardiovascular support. You're going to give tranexamic acid early to fight that hyperfibrinolysis. And look, if you have ECMO available, it has the best outcomes for refractory shock, so get that team involved immediately. All right, let's just lock in the high-yield points you absolutely need to know, both for your fellowship exams and, for your next shift on the floor. These are the absolute must-know facts. AFE can happen to any peripartum patient. Remember that two-phase pattern, the massive significance of seizures, and your core management priorities. And critically, remember, you cannot manage this alone. This takes a huge team effort. Surviving that initial arrest is really just the beginning. AFE has an incredibly high mortality rate, and neurological problems occur in up to 50% of survivors. This just underscores the absolute need for ongoing, aggressive, multidisciplinary care up in the ICU. So, if you found this high-yield explainer useful for cutting through the complexity of a true emergency, let us know what critical EM topic you want us to break down for you next. Just drop it in the comments. And hey, don't forget to like and subscribe for more guides that are designed to help you prepare, perform, and excel when it really matters the most. Train hard and stay ready.